I had a wreck in 2020 and I lost my leg below the knee. And
I'd like to welcome everybody here this afternoon. We still have members that are coming in. We've got some conflicting committees, and so obviously sometimes we gather at places on taking votes. We are not voting on bills today. This is an informational meeting that I think is very important, especially for members of our health committee and members here for other lobbyists and just people that are here in the group. Healthcare is rapidly changing, and the approach of healthcare is also rapidly changing, obviously. And we're going to hear some testimony or discussion today from different folks, and what they're bringing today is very important. It's going to really speak to the access of healthcare in this state, what is available. This is the thing that I want our members to hear. When we go home, we get a lot of questions about healthcare, among other things, and to know where to send people, when to send people, how to send people, is part of our job, and that is to help people in our community. And so we're going to have some of that today, and I think you've all seen the agenda. We're going to be hearing from Liz Coates first, then later Commissioner DCH, Kaylee Noggle, and then Grant Thomas. All three of these folks have worked very hard in their careers. Liz is from Gainesville. She works in our charitable clinic there, and a clinic that I've volunteered in the first year it opened, the Juice Clinic. My son is the general director right now. We've been very successful in having a lot of physicians and dentists volunteer there. We have the dental school that brings their students in, and we do an extern program there with them. It serves a great need in our area. And I'm going to hush up and ask Liz to come up and speak, and I think Becky will give you the introduction. Becky Riles. Thank you.
Thank you, Mr. Chairman, members of the committee. I'm Becky Riles, representing the Georgia Charitable Care Network. And before I introduce Liz, I would like to just tell you a little bit about GCCN. The Georgia Charitable Care Network is a system of free and charity clinics. Each clinic decides the services that they have the capacity to offer for the community based on the need that exists. So they are a safety net provider for primary care. There is a map in front of you that shows the sites that free and charitable clinics are located around the state. There are 98 free and charity clinics currently in Georgia. And as you can see, they are there's a large concentration in the Atlanta metro area, but they are divided geographically pretty well around the state as well. Each charity clinic has its own governing board of directors, so they decide the services that are needed in the community. In essence, it's designed to be an access point to primary care for individuals who, for whatever reason, cannot otherwise find a doctor who would take an appointment for their visit. 95% of the patients at a free and charity clinic around the state are uninsured. So their focus is on individuals who are medically underserved. They may have underlying health problems, and they work not only to get them in to provide the health care that they need, but they also provide a tremendous amount of wraparound services, focusing on social determinants of health and connecting them to other resources in the community. So with that, I would like to Mr. Chairman, if it's okay, I would like to call on one of the board members of the Good News Clinic in Gainesville, and that is our own Mike Giles, who serves on the board and has worked with Liz for a number of years, and would like for him to introduce Liz.
That'll be fine. Thank you.
Thank you.
Thank you very much, Becky. Mr. Chairman, members of the committee, I'm going to take off my poultry hat and put on my volunteer hat. And it's such a pleasure to be able to do that. And I hope what you'll come away with today is an appreciation for how special a place Good News Clinics is, and the clinics similar to it throughout the state. It's a place that changes lives every day. It's a place that saves lives. And we exist, I think, and thrive because we live in a generous community. We also, the clinics has strong partnerships with Northeast Georgia Health Systems, Longstreet Clinic, other healthcare providers. So it provides a really much needed service in a very caring way. And it's my pleasure to introduce our leader, Liz Coates, Executive Director of Good News Clinics. Liz?
Thank you so much, Mike. And Mr. Chairman and members of the committee, I'm just so thankful to be here. We appreciate you taking the time to learn a little bit about our work and the things that Good News Clinics are doing, but also that same work, knowing that same work is happening across the state in the 98, 97 other clinics that are taking care of the low income and uninsured. And you know, they say that a picture paints 1,000 words, but I think a video can do better. So if you don't mind, may I show a very brief video that I think will speak perhaps better than I.
I had a wreck in 2020 and I lost my leg below the knee. And amazingly, when I came in, my doctors informed me that he had an amputee program going on here, and a guy named Jason came and talked to me that day, got my information, and set me an appointment up and within a month, I had a new leg.
For Good News Clinics, what we find are that our patients lack access because of insurance and because of income and because of circumstances in their lives. So our role in the larger healthcare system is to be the safety net, to provide access, to be the thing that catches those patients when they fall through the cracks because of income, poverty, and insurance status. We have a niche role, but we have a role that people wouldn't live without in many cases.
Well, I lost my job due to COVID, and I had to move in with my daughter. I receive on my diabetes 2 prescriptions. I receive a Jardiance prescription, which if I had to pay out of pocket, is like $622 a month. And Trulicity is a weekly injection that I take, and that runs about $700 a shot. So you're looking at $2,800 a month. There's no way I could afford to take care of my diabetes without the program.
My name is Julie Poole Knotts, and my parents were Dr. Sam Poole and Bess Poole. And Daddy would always say, we will all suffer, we will all have pain, but it's tragically worse when you're poor and when you have no health insurance and you have no care.
Being able to have the opportunity to interact with these communities and these populations and getting the chance to actually get my hands into helping them directly is something that I find really fulfilling. And I feel like it's a really good use of my time to be helping the community in Gainesville.
Not everybody's comfortable with faith, but we want everyone to feel loved. We want everyone to feel respected and appreciated, and those are things that we've built into our core values.
I feel like we make them feel like each one of them is important enough. Doesn't matter what color you are, where you come from, what's your socioeconomic status, like you're gonna feel good here with us, so we'll make sure of that.
They don't make you feel like you're not worthy or a burden. Actually, I will say I've probably gotten better care through the clinic than I have private doctors.
Without good news, I wouldn't have been able to make it. I didn't have any insurance. I couldn't provide it. It's really a blessing from God. You know, to have these people here to provide all the people that they provide with medical assistance and your medication and doctor's appointments and surgeries. I'm talking about sending you to specialists. At zero charge, so it's amazing.
In 2017, 2018, we started pulling data. We started looking at the growth of the area. Okay, so I hope that just helps a little bit with painting the picture of who we serve and how we serve as free and charitable clinics and at Good News Clinics in Gainesville. So just to give you a little bit of background about our organization, and each of our many, 98 have boards and set their own standards for eligibility for our patients, but we serve patients who are within 150% of the federal poverty line. They must live in Hall County, and they must be uninsured. And so what we find is that these are the folks that would fall through the cracks otherwise, and don't really have access to insurance for many reasons. We have a lot of part-time employees or low-income employees. And so at the end of the day, we provide several services. Becky mentioned wraparound services. So everything starts with primary care for us, but as Representative Hawkins, I'm used to Dr. Hawkins. As Dr. Hawkins pointed out, we have a dental clinic, and so we're able to provide medical services, and we end up seeing about 1,000 appointments every month in our little clinic. Our dental clinic serves between probably 400 and 600 right now dental appointments. We have a counseling program with what equates to 2 full-time licensed professional counselors and a host of student interns who are 4th year to provide counseling services, which are in short supply and high demand in our community, certainly with all populations, but more inaccessible for ours without us. And we see about 200 appointments there. We also provide, we have a dispensary, so we're able to provide all the medications that we prescribe for free, because we're very aware that even patients who are being discharged from the emergency department, for example, if they are indigent and uninsured, cannot afford that prescription that they leave with in many cases. And so those patients get funneled directly to us through the Northeast Georgia Health System. through Epic, which has been wonderful because we all align now. And we're able to take those patients in and go ahead and make sure that they can get their meds filled so that they don't wind up back in the hospital, which is a big point for us to make here today, which is we really keep people out of the hospital who cannot afford to be there. And for whom it's quite a burden for them and probably the health systems as well, despite the incredible charity programs. So we really work alongside them to provide all of these services, and we do so on a $2.6 million budget. So we treat 3,500 patients on average, 3 to 3,500 unique individuals with all that wraparound care and free medications every year. And that's just Little Hall County. Well, Big Hall County, but Hall County. So when you think about that and you consider that those 3,500 really don't have any other opportunity for care that will not be more of a detriment in their lives in many cases because of income, it's also a lot of value to the community and to the healthcare services that we produce in so many ways because we keep people well and working. I just wanted to share with you, there's a very old study, but it at least paints a picture. UGA partnered with the Georgia Charitable Care Network some years ago. I think it was 2015. I think the cost of healthcare services has gone up a little since then. With that in mind, we keep people out of the emergency room because if you're uninsured, where else can you go for non-emergent health care? There's not another option that has to take you other than us. And so here's a quick stat. For every 100 patients who visit a GCCN safety net clinic, $50,000 is saved in avoided visits to the emergency room. So this equates in Good News case to nearly $2 million in savings in avoided ER expenses. That was in 2018. So we're talking about years ago. Now add a few years and maybe a little bit of inflation to that and some changes and we're closer to $5 million. And that's just the emergency department. That's not counting the hospitalizations and all of the other things, because by treating chronic disease, that's what keeps people well and out of the hospital, by managing those chronic conditions. I think Becky referenced that was that chronic conditions? 76%, I'm at 96%. I was gonna say 100% of the patients that we see, they're not coming for well visits. They're sick. By the time they come to us, just look at Maslow's, right? You gotta cover all these other bases. And by the time you get down to healthcare, it's bad usually by the time you come to the clinic. So by getting people well managed, dealing with diabetes, CVD in particular are huge for us. We really keep a lot of health issues from becoming completely emergent, and so it's a very important part of what we do. Good News Clinics is the largest of the free clinics. There are charitable clinics that are larger than us, but we remain the largest free. And so we do get to hear from and see a lot of the surrounding clinics that are smaller. We're 31 years old. We've had time to grow. And we also have a lot of the health system is in our community, Northeast Georgia. And that provides a ton of volunteers, which makes us able to be successful and continue to be large. But with all of that said, and by the way, I wanted to recognize Blake Fullenwider from Northeast Georgia Health System because they are one of our biggest partners. I think one question that is often asked about free and charitable clinics is how are we able to produce millions in services on small budgets. In our case this year it's 2.6. That's the highest it's certainly ever been. But we also have found ourselves unable to keep up with the demand in our community, even being the largest of the free clinics in our state. So we're in expansion right now. That's the rest of the video that I cut off was the part about our expansion and our campaign. But we're going to go from 11,000 to 20,000 square feet and add 60% medical capacity and triple our counseling capacity, because after a lot of research, we discovered that that's what the needs are in our community. We take in between 700 and 900 new patients every year. That's a lot for a small community clinic. And so just with all that said, I hope that this is painting a pretty clear picture of our role and our value in the communities that we serve. And GCCN is a wonderful partner because we learn really well from each other. One thing that I wanted to reference too that kind of sets us apart from other healthcare entities that work with low-income and uninsured populations is that we're small and nimble. So, for instance, when the COVID crisis came to town, I will never forget the day that the Northeast Georgia Health System, the Giant Health System, reached out to us and they said, you have the population, the population most disproportionately affected, we believe. Testing had just become available. The state was not doing testing at health departments yet. It was the first test kits that arrived in Gainesville, Georgia. And Northeast Georgia reached out and said, it's your folks that we're most concerned about, and we need to work with you. So by the next day, we had tents up and cars coming through. I think that was in the video somewhere as well. And we tested 1,400 people within 24 hours with a 50% positivity rate, because we can move fast. Unlike, I think, federally qualified, for example, centers and things like that, we can operate more independently to jump in when needed in crises. And so I think there is certainly not only a very pointed population, health population need that we serve, but we also have that ability to flex and move in the middle of difficult things. And all of us are growing in service lines, especially with partnerships. Good News Clinics is now, there is a very, very much a shortage of retina specialists for our population in Georgia. So many diabetic patients are going blind, often unnecessarily when they're uninsured, because they cannot get access to a retina specialist. So we started working with somebody from Emory who's really studying this, and we have our first retina eye clinic coming up on March the 18th. This is big news for our little community, and it'll really keep people and help people keep vision and be able to move forward and continue their lives. You saw the prosthetics line. It's just incredible. And we do all this with volunteers. So we have 50 medical providers who volunteer their time right now. And we have about 40 dentists. And another 150 in our Health Access Network that gives us access to specialties outside of our clinic. So it takes an entire community kind of coming together to make it work, but it can work so well, and the outcomes in our patients are tremendous. So I'll kind of close with one last example that we're quite proud of, which is our congestive heart failure clinic. So CHF is, it is rampant. There is just a whole lot of CVD that's led to CHF, and these days in age. But so all that to say, when patients are discharged after a cardiac event and have been diagnosed with CHF, they come directly into our care. They're very fragile patients, but they require, weekly visits up until a certain point, weekly labs. All of this is costly and so on, but our 30-day readmission rate for CHF patients is 4%. And we serve the entire indigent CHF population in Hall County. And that's the one clinic we make exceptions for because other counties can't get access sometimes. The national average is 22%. So we're keeping people well, we're stabilizing, the population that would not have access otherwise, and keeping them out of the hospital. So this is good news for everybody. So I guess I said closing. One more thing, and I'll stop. Unite Us is a social needs platform. One thing that we realize as well in our work is that there are so many social determinants of health that if not addressed in some way, we're not going to see the health outcomes that we could. And so we have been working with our local United Way and health system and other partners, and we'll soon pilot a program so that we'll be able to communicate with each other and send referrals directly to each other for other social needs services such as food insecurity, housing, things like that, and actually see and have a closed loop that those referrals get picked up and dealt with, or else they get kicked back to us. So all that to say, I just think that the progressive and incredible work that's happening in a lot of free clinics is probably not well known. And so it's just an honor to get to share with you a little bit about some of the great work that is happening. So thank you.
I want to thank you for all you do and the services that you've provided. Liz is a great messenger for this clinic, and she speaks around our community and probably throughout the state too. Ours is a unique clinic, but there are other clinics around the state that do similar work. Some are partial pay, like she said, like Becky said, and some are like ours. We live in a community that luckily we have a lot of partners that contribute monetarily, so we can have the drugs, so we can have the staff, because it's not just us docs that are doing this, it's staff. I remember one year, December the 23rd, I had a little girl at the end of the day, and she had beautiful little girl, Spanish girl, Hispanic girl, and she had decay between lower and front teeth. And they had her scheduled to have 2 fillings done. Well, I asked the staff if they'd stay late, and they did. We did them all, and made a big difference to a little girl on Christmas. And we actually took a picture of her, and her mother tried to give me $20 for doing that. And
And Dr. Hawkins, I would just mention we served 372 patients just like that little girl last fiscal year. So,
yeah.
you know, there's a need for children that fall outside of the ability to find access.
Right. You've got a question.
Thank you,
Dr. Newton.
I appreciate it.
Representative
Thank you
Newton.
so much for y'all's work and all the other ones that you mentioned that are similar, trying to do that. You did mention there's the free, which is what you're the largest of, but then the charitable ones, which I assume may have some income-based sliding scale work like that, and then beyond that would be the federally qualified health centers, FQHCs. Was just curious. You mentioned medications. 2 things. You mentioned medications. Are y'all able to get 340B pricing on drugs, or does that not apply to a free clinic? You just had to get them donated from somewhere or bought?
All of our patients automatically, because of their income and lack of insurance status, qualify for patient assistance programs through the pharmaceutical companies. Right. So I always joke that 4th-year farm students love to come to our clinic because it's a whole new way of dealing with that. But so most of our meds are going to come through those, but then the budget for meds we have to purchase ends up being about $100,000 a year, and we purchase those from the local hospital dispensary. But one other main source is there are some organizations like Direct Relief, AmeriCares, and every week we get a menu of what they have available in a formulary, and then we can select, and they send those to us for free. So there are charitable organizations that are stocking clinics like ours.
Well, thank you. I know that keeping up with that can be a big deal too. Just one last question. Starting in July, I think we're going to hear from the Department of Community Health shortly. There will be a program starting in Georgia expanding Medicaid for people under 100% of the poverty level. You mentioned many or maybe all of your patients, they're below 150, but many are probably below 100. Is there a need, especially when you're having to send them to specialists or get other procedures, where having them, if they're eligible, receive Medicaid? Will you be prepared to help them transition, or is that going to make them leave your clinic? Or
That's a great question. So we work very closely with the navigators, the financial navigators and assistance navigators at our local health system. We don't have the manpower to do a lot of that on site, but through the Unite Us program and working closely with the financial navigators, we certainly want to see people get enrolled when they are eligible and can into Medicaid. Absolutely. And same thing, we have patients, you saw one that'll graduate into Medicare, and we're going to make sure that you go ahead and get you enrolled in Medicare. So we're absolutely trying to help patients navigate and take advantage of the resources that are available to them.
Thank you for what you do. Appreciate it.
And Chairman Newton, I'll just add to both of your questions. One about 340B. 340B is specific for entities that are funded from the federal level under 330 Public Health section through HRSA. So while that does allow for drugs to be purchased at a discounted rate and then offered at a significant discount for the patients, the free and charity clinics do rely on the patient assistance program and other donations to take care of the prescription needs.
Thank you.
In reference to your question about the Medicaid unwinding, one of the many roles that the network provides for its members is any kind of assistance that a clinic may need in operations, in getting up and running, in helping connect with partners, either within the community or at the state level. And so the Georgia Charitable Care Network and their executive director, Donna Looper, does a tremendous job in providing assistance to the members. And one of those ways that the network assists is they are currently in conversation with the Department of Human Services, who will be responsible for the Medicaid unwinding, to be sure that the clinics are prepared to inform individuals that there will be a recertification of their Medicaid eligibility for those clinics that do see Medicaid patients. And then likewise, if they find themselves no longer eligible after the Medicaid unwinding, connect them with hopefully some form of insurance, either through the exchange program or through the waiver, as you referenced.
Well, thank you. I know there will be a big flux because some people who are on Medicaid will be off and no longer eligible, and they may need that, as you mentioned, people who fall between the cracks. But then there's also people who may need to, who actually may be eligible to get on Medicaid, and you can't accept Medicaid. Is that right? So, but you have a system to partner with people. Thank you.
But there are several of the charity clinics within the network, the Free and Charitable Clinic Network, who do see Medicaid patients. So as Liz referenced, some of her colleagues around the state do see Medicaid patients and also charge on a sliding fee scale for individuals who are uninsured or underinsured. We did want to, the chairman asked that we leave a few minutes for some questions and discussion. So at this point, we'll open that up unless you're ready to move on. Yes, you're looking at your watch, Mr. Chairman.
No, we're good.
If with your permission, Mr. Giles and I were having a conversation in the hall this morning specifically about how Good News stepped up to the plate when there was a need in their community, and I would like for him to offer just a few comments about how that helped Gainesville and Hall County transition through the pandemic.
Thank you, Becky. I think back to 2020. We were here on Crossover Day, just like we were 2 days ago, and then the world changed. And then we started communicating with our members and then really communicating with our healthcare providers and Good News clinics. And out of this came a group of community people, employers and healthcare providers that were talking on a daily basis. And one of the things that Good News Clinic stepped up, and you heard the other examples with the healthcare system, is when vaccines started rolling out, we knew that adoption of vaccines was going to be most likely if you were able to provide it in the workplace itself. And so our members, our companies, our large employers wanted to be able to do that, and not in all cases did they have the internal resources to do that. And so Good News Clinic stepped outside the clinic and moved into the workplace, and again, as an example of how nimble they are and supportive of our community. It was a really big part of our response and the overall community's response to the pandemic. So we thank you.
We still have one more time.
Thank you. We still have one more time before Commissioner Noggle gets here. So are there any more questions? It looks like maybe we know it all, but I don't know. I don't think so. Let me ask you one. How many clinics do we have in the state that are like Good News, that are totally free? Do we have any idea of the number?
Do you know the free versus charitable?
I don't know that answer off the top of my head. I don't want to misspeak. So let me
Right.
get that number to
Okay.
you. So between free and charitable clinics, there are 98,
Right.
as you see on the map there. But I don't know the exact breakdown, but I will certainly get that for you and provide that for the committee.
How about FQHCs?
So there are the 98 free and charitable clinics, and then the federally qualified health centers have 229 clinical sites. So collectively, I hope that demonstrates for you all that as you have constituents who are looking for access to health care and access to a medical home, hopefully there's a free or charity or federally qualified health center. At least we know there's one in each of your districts. That is for certain. So don't hesitate to reach out to me if I can be of help to you to connect you to either the network or the association for the community health centers.
I would ask you if you would send that to me, and then I'll distribute it. I'll make sure the committee gets that, because I think it's very important. In fact, I think our whole house could use that information, because when we go home, we get questions like that, right? And it's nice to know where we can send folks for help.
And I would add, Mr. Chairman, that individuals find a medical home at a free and charity clinic or federally qualified health center for a variety of reasons. Either they have been employed and lost their job, or their employer does not provide health insurance. So they may have an individual in their family who is employed and has health benefits, but the rest of the family does not. Many of the free and charitable clinics are affiliated with churches, so they are a very strongly faith-based organization.
Right.
And as Liz mentioned, they provide their own requirements for their clinics. So there's one clinic, for example, in South Georgia. As a condition to be a patient, you must attend life skills class, is what I would call it. It's either a job training or financial planning, or it may be how to interview for a job. So it's a condition that the clinic sets, but yet it gives the individual some advantage as they become healthier. Then they're more able to go into the workplace setting and become productive again for their family.
Yeah, I can tell you, as someone who volunteered in the clinic and also did hospital dentistry for the first 10 years, this is so important of keeping people out of the emergency room. It's not only the dollars being saved, but it's the pain and suffering that they have that prevents them. It helps prevent them from going through, because they get things taken care of, their issues taken care of, but before it becomes such a grave emergency. And so it's what y'all do is very, very important. Representative Cannon.
Thank you, Mr. Chairman. To that end, to Chairman Hawkins' point about keeping folks out of the emergency room, is there a pretty good relationship between you guys and the local hospital, and how's that work? Is there like a referral process, or is there a communication between the two entities to make sure you kind of catch everybody?
That's one of my favorite questions, because we've gotten so much better at working together over the years. So for our clinic, I would say not for every clinic. Mm-hmm. That's an unfortunate thing. And if there were one thing I could fix about the free and charity clinics overall, it would be that every hospital really did participate more closely in relationship and partnership with their local free or charitable clinic, because it makes such a difference. But we're very blessed in Gainesville and Hall, because Northeast Georgia Health System their foundation went to bat, and they use Epic, which is their electronic medical record system. And they raised $1 million to implement that for Good News clinics so that we would have visibility. And that covers 8 years of service between us. And so they can now directly refer patients to, we have an employee, that's all she does, is take in those referrals. And she'll have to triage, make sure they actually qualify for our services and so on. But yes, that down to the system, we have a very strong relationship, and a big part of what we're doing together for the health of the community is fantastic. And the social workers and caseworkers from the health system know us well. They have a new pitch program to keep people from overutilizing the emergency department, and they try to redirect them to what's appropriate for them. So this is a program of the health system, but they're in our parking lot every day. So they actually will bring patients to us sometimes and say, we've got to get you set up over here because this is what's going to put you on the path to being healthy, not just the Band-Aids that we can continually do at the hospital and emergency department, which is get you out of, get you stable and get you home. They need the primary and long-term health care.
And I would add to that, Liz mentioned how important it is once the patient is discharged from the hospital or even the emergency room, that they get not only a referral, but when Liz and her team knows that an individual has been discharged from the hospital, they get a phone call. So it's a follow-up, not just, here's your appointment, but there are individuals who will make sure that they get in for those follow-up visits in hopes of not being readmitted to the hospital unnecessarily. So I hope that answers your question. Representative Cannon, in some cases there are free and charity clinics that the hospital provides space, and so they are located on the campus or one of the campuses of the hospital locally. And another example that I would give you of a hospital relationship, and this is an example with a federally qualified health center, knowing the dire need that we have in Georgia for OBs and the importance of prenatal care. There are several hospitals who have asked the health center to provide the prenatal care and do the delivery at the hospital rather than the hospital having that administrative staff and that burden. So it allows the hospital to keep the labor and delivery department open, but it also allows the health center to do all the wraparound services that may be needed for prenatal care. Fortunately, thanks to you, they will now immediately be eligible for Medicaid once they become pregnant, and will be eligible for Medicaid for at least 12 months. That will be a game changer, I can tell you. And so for either a health center or a free clinic who knows those individuals who are more likely to be struggling either from a health perspective or from an economic perspective, they can then better ensure that they get the prenatal care that they need and hopefully have a better outcome in delivering a healthy baby and keeping the mother healthy as well.
I just had a text from Donna Looper. Donna Looper is the director of the clinics here in Georgia. And by the way, her daddy was a dentist and her brother is a dentist. So I'm proud of Donna Looper. She's a little bit under the weather right now and could not come. But she just sent me a text. She's watching this online. 62 clinics in the state of Georgia are free clinics out of this. What'd you say, 98?
98,
Yeah.
yes.
So
Thank you, Donna.
Yeah, thank you, Donna. So what I want the committee to really come away with part of this is it's up to us also to go home and talk to our communities to build this kind of structure in your community. Counties can come together and join the hospital in that whole area and hit the business community and hit other points to raise money to do a small print of this. When we started off, we were small. I mean, we were in the building actually where the people would drop clothes off and appliances and all that stuff. And we were back in the corner of that very same building right next to the Gainesville Glass Company. and would actually serve lunches in that same building too. So we started off small. This is something we can all do throughout Georgia. You don't start off with a clinic like they've got now. We all start small, and then also get your hospitals involved. I mean, I think Anna Adams is sitting right there. How many hospitals do you think are involved now with these clinics?
I think it's going to depend community to community, but we could do an assessment of our members and find out.
I know the hospitals have been very, and Blake could attest to that, the hospitals have been very helpful in this approach. This keeps, like I said, it keeps people out of the emergency room, but also keeps costs down. And it is not a real complicated system set up. It takes work, and it takes people that are dedicated, and it takes some thought. I mean, back in 2007 when we were doing this, I was on the other side of this building and started looking at it, and I was talking to our retired physicians and dentists and said, "Why don't you come?" Well, they don't have liability insurance anymore. So we passed some legislation that provided sovereign immunity for the docs and all the volunteers at the clinics. That was one of the bills I did the second year. And we did some other things by getting continuing education credit for our providers. Mm-hmm. So when they go down there, they actually walk away with some hours that we need to keep our license going. So there's some creative things we can do. And I know that this committee is very smart and think of things like recess for our school kids, right? Good idea. So I challenge you all to think about this and go home and contact people that are already doing this, like Good News or Becky Riles, and spread the word and get this going through the state even stronger.
Thank you, Mr. Chairman. We appreciate this opportunity very much. You do have the information in front of you that gives you some excellent data in terms of the return on investment, as Liz so eloquently mentioned earlier. So please take the time when you have it, and we'll be glad to come visit you also after the legislative session, and would love to have you visit any clinic in your district.
Right. Thank you all very much. I appreciate it.
Thank you.
Our next presentation and presenter is not here yet, Commissioner Noggle, so y'all can take a break and we'll start with her in a few minutes. All right, listen, if y'all will settle down, the commissioner is coming in the door. There she is. I would like to introduce our commissioner. I tell you, I've been around a fair number of smart people in my lifetime, going to school as long as I have. And I have an appreciation for good brains and hard work, and this lady has both. And she's here to present some information to us that I think is very important for us also to be aware of, and it's going to affect legislation for years to come. Commissioner Noggle, the floor is yours.
Well, good afternoon. Thank you, and thanks for your patience while we wrapped up another meeting. Happy to be with you today to talk a little bit about one of our most recent initiatives called a directed payment program. And I know a number of you have heard me talk about this in a number of different formats and venues, but happy to walk through it with you again today. Thank you so much. So we'll just kind of start from the beginning. A directed payment program is actually a specified financing tool. CMS authorized directed payment programs in 2016 really to allow states to work on achieving certain quality goals with other Medicaid system reforms by drawing down additional federal dollars to do that. There are some pretty specific guidelines on how these can be developed and what they have to look like, and the criteria and parameters that have to be met in order to get CMS approval. They are subject to annual reapproval. So while we do have federal approval on all of the directed payment programs I'm going to show you today, there is a pretty robust and extensive effort around monitoring and evaluation that we'll go through annually in order to resubmit for approval for the next year. What we're going to talk about, and you've probably heard these as both directed payment programs and then also something called the waterfall, and they're really two separate things. The directed payment programs make the waterfall possible. The waterfall is just a reshuffling of some things, where the directed payment programs are the actual 5 new things that I'm going to walk you through. What we submitted to CMS really is we have an existing quality plan as a state on healthcare that talks about things like improving access to rural healthcare, appropriate utilization of care, not using an ER when we really want folks to be focusing on primary care and different things like that. And then like smarter spending and how we improve our actual quality metrics in the state. And so in order to address those, we developed 5 directed payment programs. One is called Georgia Aid, Advance Health Equity through Georgia Aid. We're going to cover Medicaid uncompensated care for small rural hospitals and with reallocated DSH funding. We've got a public hospital directed payment program that's been in place for about a year. We're going to add privates to that, and then a physician directed payment program. And I'll walk you through those individually a little bit. And we'll be happy to send these slides to that, and Tara may already have them on a number. Thank you. So I'll walk you through from the left to the right. The first one is the Physicians Directed Payment Program. This program includes physician providers that are affiliated with a governmental teaching hospital. One of the pieces of this program that we will use in evaluation and annual renewal is their achievement of certain metrics and improvements, inpatient discharges and inpatient average length of stay. There are 14 affiliated public hospitals whose physicians are eligible for this program. It's valued at about $120 million, both federal and what we would traditionally call the state share. In Medicaid, the federal match is about 70% federal funded, 30% state. It's a little bit more or less in a year. It's probably a little closer to 65 right now, 67. But this is being funded for the federal funds. And then for the state share, and this is what one of the best parts about this is that it's through intergovernmental transfer. This is not state appropriation. It's actually intergovernmental transfers from the hospitals themselves. So we're using the hospital's own money to draw down the additional federal dollars. And that one was approved in January of 21. The next one is the Public Hospital Directed Payment Program. We're going to increase Medicaid reimbursement rates to those hospitals up to the Medicare equivalent. There's 58 public hospitals that are eligible for participation, and all in that's worth about $235 million. Again, federal, and then the traditional state share is funded by intergovernmental transfers from the hospitals themselves. That one was approved in November of 17. The next 3 are the more recent ones that we've seen just over the course of the last fiscal year get approval. The Private Hospital Directed Payment Program is almost identical to the public hospital. We're raising rates to Medicare, but we're just adding them into that Public Hospital Directed Payment Program. There are 42 private hospitals eligible for participation in that program. Private hospitals are private and therefore cannot enter into an intergovernmental transfer for us. So this is where a provider fee or the state assessment, the bed tax comes into play. The provider fee is how we then use those funds to pay for that state share on that program. Georgia Strong is specifically for our teaching hospitals. Currently we have 20 teaching hospitals around the state, and our definition of a teaching hospital for participation includes 5 residency slots. The purpose of this program is to really focus on our workforce. So up to 20% of the new dollars through Georgia Strong will be reinvested by those hospitals into their workforce. Additional recruitment, retention, resiliency training, and we will not be super specific or scriptive in how they use those dollars. Rather, we're giving them a lot of flexibility to design programs that will be catered to the needs of their workforce at their hospital. But we will be reporting on what those activities look like and how we're designing a single set of metrics across those 20 teaching hospitals that will report back to our federal regulator CMS to show what we were really able to do with that. And ultimately, some of the main goals of the program remain the same: improving maternal health outcomes, patient satisfaction, reducing ER days by strengthening their workforce. This program is the largest. It's valued at $700 million. We're raising their Medicaid rates from current Medicaid with about a 200% bump on top of those current Medicaid rates for inpatient and outpatient charges in those hospitals. Those hospitals are a combination of public and private teaching hospitals. So the publics are funded through their intergovernmental transfer, and the private hospitals are funding the state share through that provider assessment. That was just approved in December, right before the holidays. And then the final program, directed payment program, is Georgia Aid. This program has at-risk dollars and includes Grady Hospital and Augusta University as the state-owned and operated hospital, and Grady being the single largest provider of Medicaid services in the state. Similarly, we're raising their Medicaid rates from current Medicaid rates to their average commercial rate, again calculated on inpatient and outpatient services, valued at about $345 million for this program for those two hospitals, again funding the state share through an intergovernmental transfer. That program was approved in July. Because of those 5 programs working together, that's about somewhere between $950 and $1 billion net new dollars to the state for those hospitals specifically. Our estimates are really based on utilization and inpatient and outpatient services from 2021. At the end of this fiscal year, we'll true up the actual claims and utilization and true up those numbers, and so we'll get final math closer to the end of the fiscal year. But because of some of that, we're able to do then what's called the waterfall. DSH is the disproportionate share hospital allocation, is a federal program that Georgia gets about $435 million allocated a year to allocate to our hospitals that provide Medicaid services, and traditionally has been allocated on a proportional or pro rata basis dependent on their proportion of Medicaid services that they're providing. The more Medicaid services they provided, the larger their share of the DSH funding. The top shows kind of how it's been done to this point. We've allocated a certain amount to small rural hospitals, hospitals in counties with 50,000 residents or less, and hospitals with 100 beds or less. Grady, as the single largest provider, consumed about $105 million of that $435 million itself. However, because we're raising their Medicaid reimbursement rates through the directed payment program on the previous slide so significantly, they become ineligible for this program. Their meeting have already met what's referred to as their hospital-specific limit, which is essentially the calculation of their Medicaid costs. Because they're no longer eligible, we get to take that $105 million, and there's a few other hospitals that are going to hit their hospital-specific limit as well and free up some money. We get to take that money and waterfall it down to other hospitals. And we're changing the allocation and how we prioritize that funding. And this is the one piece that's still pending federal approval. It's not how much money, but just how we prioritize it. So we're going to reprioritize and send those dollars to our small rural hospitals first, and completely fill the hospital-specific limit or cover the Medicaid costs for all of those hospitals first, before we siphon that money over to the second pool, which is the urban and the non-small rural hospitals. So in total, when you take all of the directed payment programs and the amount we're raising rates, which reduces the Medicaid gap or cost, and then by reshuffling this money through DSH, the overall outcome, which I'm sure you've heard talk about a little bit, is that for Medicaid uncompensated care costs, not costs related, not costs related to Medicare, not costs related to their bad debt, but their Medicaid uncompensated care will be cut in half for the state and eliminated for for these 61 small rural hospitals around the state, which is pretty significant. Again, net, the total program is about $1.6 billion, $1 billion of that being the new federal funding. Couple other just details if you're interested on how some of the things are actually calculated. The DSH limit or the hospital-specific limit, there's some details there. And then I've just listed some estimated impacts on some of our hospitals. About 58 hospitals will benefit somewhere between $15,000 and $1 million all the way ranging up to 13 hospitals, again, based on their Medicaid delivery of services of about $25 million all the way up to just under $100 million for 13 different hospitals. And then graphically, we've tried to show it in a different way, kind of where we are now as a state between the green bar showing kind of what Medicaid is covering, Medicare equivalent, and then the red illustrating Medicaid uncompensated care costs for small rural, private, and public hospitals. And then in the future state, you see that those Medicaid uncompensated care costs are greatly reduced, although there are still uncompensated care costs related to Medicaid around the state, but raising those new rates pretty significantly. Again, all 5 of those directed payment programs have received federal approval. We're waiting on the allocation methodology change. We think that should be coming hopefully any day now. And in fact, just a little bit of update in the last couple of weeks, we've actually sent payment notices to the hospital. We expect funds to start leaving our department by the end of March and hitting actual hospitals by about the 2nd or 3rd week of April. I always feel like I cover that really quickly, Mr. Chairman, but I think it's because I've done it too many times. So I'm happy to take questions. We can back up and go over anything in more detail that anyone wants to. We've started sharing a few hospital-specific estimates with some folks here or there, but we're a little hesitant to share those until we get the full approval, because that waterfall, the dish on the end, is really what makes a significant difference. After that approval happens, every single hospital system or hospital in the state will benefit from this program. There will not be anyone that doesn't see a benefit or an increase in Medicaid funding from this once that final approval comes in.
Okay, you do have a question. Dr. Newton?
Thank you, Mr. Chairman. Thank you for that. I'm beginning to understand it. This is my 3rd or 4th time. Do you mind going back to the one that showed all 5 of the programs and kind of a couple of questions there? You mentioned like the 14 of public hospitals or the 58, and that they would be funded by intergovernmental transfers from their bed tax that they're already paying, or
No, so the publics are just whatever fund source they have that they want to put up, they put up in an intergovernmental transfer. We draw down the federal funds and then they get it all back.
The private hospitals then, they pay the same bed tax they've always paid?
No, there was a slight increase to the private hospital provider assessment
to help draw
fund
down
this.
those extra dollars.
Correct.
Okay. And then one ahead. There, yeah, the small rural pool, 130 million, and I know you said 61 hospitals, so just round numbers, that's about $2 million or a little more than $2 million if you were to average it. And I know there's a big range of small rurals, but were they already getting like $1 million, and now they're going to get 2, or were they getting 0 and going to get 2, or were they getting?
It's kind of.
Or ballpark.
It just depends, honestly, because it's going to depend on, they were getting, the formula was totally different. It was everyone could get it was a proportional share of the 435 based on their proportional share of overall Medicaid delivery in the state, up to, there was a cap of about 75% of their hospital specific limit that would have capped them out previously. Going forward, it really depends which one of these programs they're going to fall in. On which directed payment program, which will dictate what their new Medicaid reimbursement rate is, which then impacts this final formula of their hospital-specific limit. What Medicaid costs do they have left after we increase those Medicaid rates, and run the math, and then that would be the limit they would have on that dish funding. So it's a little bit apples to oranges.
Well, I think that's an impressive number between the 20 teaching hospitals plus the 2 that do a tremendous amount of teaching, Augusta University and Grady. The teaching hospitals, which we've all been trying to figure out how do we increase the workforce in healthcare and deal with the challenges of nursing students, medical students, and everything. That's a significant bump to go to 200% over
Medicaid.
What it used to be, or your average commercial, which probably that much are a little higher. So thank you for doing that. I'm glad. I mean, that's going to help train the people who are going to take care of all us one day.
Thank you.
Thank you.
For those on the committee, the importance of this just cannot be emphasized enough. At one point, and Jimmy Lewis in the back will tell you, our rural hospitals, well, all hospitals were being reimbursed about 80% of costs with Medicaid dollars. And so that's been a tough road for our hospitals to go down. And what Commissioner Nagel's been working on and with this approach is going to really help and stabilize our hospitals. Representative Mitchell.
I agree with you, Mr. Chair. I'm glad you're here, Commissioner Nagel. As an aside, to start off, I think it would be unfair for me to ask you what you feel that the total expansion of Medicaid would do to this process. I'm not going to ask you that.
Thank you.
But what I will ask you is, has your department put any resources aside for the so-called Medicaid unwinding? I'm hearing that upwards of 500,000 Georgians will lose these resources simply because of how the process is going to be rolled out. And I'd love to hear what your department is doing there. And also I want to ask, now that we've had a major hospital closed in this city, what impact has that had on the delivery of health care, particularly in the metro area? Where are those patients going?
Sure. So I'll start with Medicaid unwinding first. We've been working on the state's unwinding a redetermination plan for many, many months. For many, many months, the state did not know when that date was coming, and so we were continually, every 90 days, prepping for it to be the 91st day. And so we've had an operational plan ready and in draft and have coordinated and had numerous conversations with CMS about what that plan looks like. Our intent is to minimize disruption to our members as much as we possibly can, but recognizing under current federal law that there will be members that lose coverage. But our goal is to limit that, and so that our team and with our sister agency at DFACS whose caseworkers actually perform those eligibility determinations, that they are staffed and have the support that they need, and that our departments are working together to ensure that we handle all those members as best we can. Those that do get redetermined, I think our message to them right now, to all 2.7 million members, is to make sure that we know how to reach them, that they pay attention to the mail that they're getting or the emails that they're getting, and that we need to be able to get in contact with them so that they don't get erroneously terminated from coverage because of just a failure to respond. And I think we're continuing to put in place operational improvements to do that. We had even a call with CMS even earlier this week. Russell and I traveled and had conversations with CMS up in D.C. Even last week to talk about how we're going to ensure that we do that properly. One of the things that we're hoping to do is to bring up Georgia Pathways on July 1st. That will be, we are planning to delay redetermination for members that we believe may be eligible for coverage under Georgia Pathways, so that we can fully operationalize that option for members and then come back and do those redeterminations for those members once we can soft transfer them and give them another option. Similarly, for members that we know that no longer meet eligibility requirements for Medicaid, they'll be soft transfer, warm transfer over to the federal exchange or state exchange if that's up, and to assist to see if they qualify for a subsidy on those exchanges. So we're doing what we can, as well as working, rolling out a PR campaign and working with providers and advocacy organizations to communicate with our members and providers and others to make sure that members know what's coming and when that's going to happen. Your second question related to the hospital closure. I think we've certainly seen an impact. I certainly try to stay in touch with a lot of the hospitals around in the metro area. The governor issued an executive order, I believe, a couple of months ago that allowed for some flexibility for some additional hospitals in the city to open additional beds, and we've seen some respond and do that. I know that Emory has been working on that. Piedmont's certainly seen an influx in patients, Emory Midtown as well as Grady, and so they've risen to the challenge to take care of the patients that are coming to them. At the same time, I know they're all also working on efforts to make sure some of the things that we're focused on, which is like appropriate utilization of care, that we get folks into primary care and preventative care in order to limit the number of folks showing up in an ER. So it's a holistic approach. It's going to take a lot longer than the couple of months we've had, but there has been some significant work done in those areas.
Great. If I may, Mr. Chair, will you provide us with a contact for constituents who may call us, as they often do when they lose their benefits?
Yes.
So that we will have someone we can be in touch with to make certain
Absolutely.
that they can
In fact, I think there is some specific collateral and materials that are being prepared directly for each of you that will be shared probably in the coming weeks that we'll make sure you get.
Thank you, Mr. Chairman.
And also for our members, this is Russell Carlson right there. I've known Russell for 20 years, I guess. Very hardworking, intelligent fellow. If you cannot get a hold of Commissioner Nagel, Russell Carlson, call him. He knows. I have his cell number, but I won't give that out. Okay. Representative Cannon.
I'm not sure about those words about Russell were true, but take it at your word. How do we ensure that you and Russell and Dr. Burke stay at DCH indefinitely? That's what I want.
We'll talk about that later, sir.
My question is, so if I get a call from my hospital CEOs in my district and they say, thank you for this additional money, it's really helping us out with our indigent care, and then they say, well, what about next year and the year after that? What can I tell them?
I would tell them that our focus right now is getting these dollars out the door correctly and implemented correctly, and remind them that in order to ensure that we get a next year, they need to meet the metrics that we've defined and that we'll be continuing to share with them in policy and operations manuals, and that they need to use the dollars wisely. I mean, we're also trying to prep hospitals on that, especially some of the smaller rural hospitals that have critical needs immediately. They're free to use them how they want, but we're ultimately going to have to show improvement in these metrics. Grady and Augusta, 90% of their funding they get, 10% is withheld until they hit certain metrics. So we need them to do what they need to do programmatically to move the needle forward on some healthcare actual quality goals, so that we get the chance to get reapproved on these things. Again, they can use the dollars how they want. My encouragement, I think, to hospitals is to look at their cash flow. We get calls, several times a month with hospitals that are short on cash, don't know what they're going to do. And I think from a finance perspective, we would just encourage hospitals and have those conversations regularly. If you're about to get an influx of money, think through that strategy on how to use it and how to make sure that that don't bank on it every year. It could be one-time funding. We don't want it to be. We're all going to work really, really hard to make sure that it gets approved annually, but just to be a little strategic in how those funds are used.
I also want to recognize Senator Dean Burke. I didn't see him sitting over there. Another great resource for our members. He was a director at one of the hospitals down there in Southwest Georgia. He's an OBGYN, so he sees healthcare from all different directions. Another valuable member to the team. I will say that, as you heard, this is a mammoth undertaking. It's going to take us all to work together to help them, because we're all in this same boat together. When things don't work, it's not just them, it's us. And so it's incumbent upon us to work with this department and help them in any way we can. And I want to thank you for all the work that you've done and your entire team. Thank y'all. Thank y'all. Okay, and our next presenter is, I see him sitting in the back of the room, Grant Thomas. He is the Director of the Governor's Office of Health Strategy and Coordination, and he's here to present on the FY 22-23 health initiatives. The mic is yours.
Thank you. We'll just take a minute to get the slide deck up and get it handed out.
Sure. Well, he's working on this. Let me just say, I've been also very impressed with this young man. He's taken a lot on, and his knowledge base is extremely wide, and I learn something from him every time we speak. So, when you're ready, you can begin.
Perfect. All right, I think we're ready to get started. You should have the slide deck in front of you, and then I'm going to be going through it right here. But good afternoon, Chairman Hawkins and members of the House Health Committee. Appreciate the opportunity to get to be before you today and present on our office, provide an introduction to our office for those of you who aren't familiar with the Office of Health Strategy and Coordination, as well as present on several health initiatives, the waiver programs, the governor's waivers, as well as the implementation of FY22 and FY23 health initiatives that our office has undertaken. With me today, we have Elizabeth Holcomb, who serves as Deputy Director and Legal Counsel. So appreciate her being here as well. But Chairman Hawkins, thank you for the kind introduction. And I serve as Director of the Governor's Office of Health Strategy and Coordination. We are an office under the executive branch that operates within the governor's office and is administratively attached to the governor's office of planning and budget. I just wanted to first give a background on the office for those of you not as familiar with us. We are a relatively new office in state government. We were established through House Bill 186 during the 2019 legislative session, which, as you might recall, that year a lot of different health initiatives were compiled into that bill, and that bill ended up passing at the end of the session. But one of the key provisions of the bill was the establishment of our office, and really what our goals and what we seek to do is to help facilitate collaboration and coordination among the state's health agencies. So we have several large health agencies in the state with DPH, DCH, DHS, DBHCD. We have several smaller health agencies, and then other agencies that also play a role in healthcare and healthcare policy and the provision of healthcare services and delivery of those services. And so there's a lot of activity going on, and we have the benefit of having insight into all of it and helping to coordinate those policies and strategic initiatives on behalf of the governor and on behalf of the state. So the powers and duties of the office, as I mentioned, include coordinating state health functions and programs, serving as a forum for identifying Georgia's health issues of greatest concern, as well as promoting cooperation from public and private stakeholders. House Bill 1013, passed in the 22 legislative session, also assigned our office the additional responsibility of overseeing the coordination of mental health policy and behavioral health services across state agencies, and we also advise the governor on healthcare policy and pending healthcare legislation. Governor Kemp appointed me to the position in the summer of 2021 after the office was funded for the first time. So even though the legislation establishing it passed in 2019, we were funded for the first time in the FY 2022 budget. So we've been in operation for a little over a year and a half now. We'll just say that the ability for us to undertake projects. I forgot to move the slide. The ability for us to succeed and work on different projects and initiatives really relies on the partnerships that we've developed with our fellow agencies. So really, some of them are in the room today. Really appreciate the partnerships we've been able to develop to work on these issues, as well as, for example, with the waiver programs, which I'll get into in a second. Commissioner King and his office, the Department of Insurance, have been instrumental in helping us to implement the Georgia Access waiver with the reinsurance program, as well as pursuing our initiative to create a state-based exchange. So really appreciate their leadership. So I wanted to first, Chairman Hawkins, we discussed, kind of give an overview of the governor's waiver programs, which I know you all are pretty familiar with at this point, but just kind of wanted to go over the history and the rationale for the state taking this approach. Governor Kemp, in his first legislative session in office, pushed the Patients First Act, which granted the governor the authority to the governor and the Department of Community Health to submit two waivers, one Section 1115 Medicaid waiver for limited expansion of Medicaid up to 100% of the federal poverty level for able-bodied Georgians between the ages of 19 and 64, as well as the Georgia Access waiver, which is targeted towards the private individual insurance market, really bringing some reforms and relief to individuals on the private insurance market so that they could have more options, create more competition, have more carriers, and hopefully decrease premiums while also increasing enrollment and getting people covered. So I'll first go into the Georgia Access Waiver, which has two components. The first component is the reinsurance program. Reinsurance is essentially insurance for insurance companies. So it operates as a partnership between the state and federal government, in which the government pays a portion of the highest cost claims to insurance carriers to help them keep premiums low for the entire insurance pool. So one of the changes that the Affordable Care Act made was now insurance companies have to price premiums based on community ratings. So they have to charge everyone the same premiums regardless of health status. So what this program does is really provide that extra payment and relief so that they can the carriers can get assistance with the highest cost claims, and they can keep costs low for the entire insurance market. That program went into effect in 2022, so we're now in our second year of the reinsurance program and already seeing significant progress and results in the individual market. When Governor Kemp first took office, there were only 4 carriers in the individual market. Today, there are 10. So there are more options and more competition statewide. Premiums have also been reduced by an average of 12.4% statewide, which leads to an average reduction of $1,000 a year for the average Georgian, which is $83 per month. And the great thing about this program is it's really targeted through a tiered approach to the areas that were most underserved and needed the assistance the most, that had the fewest number of carriers, that needed more premium relief. So in rural counties, the premiums have gone down between 25 and 40%. Since the program has been implemented, which is really significant progress. The number of counties when Governor Kemp took office that had only one insurance carrier was 118. So 118 of our 159 counties only had one insurance carrier option. Now there's only 3 counties statewide that have one insurance carrier. So some significant results there. And then overall, the enrollment has also increased in the individual market. When Governor Kemp took office, there were 383,000 people in our individual market. Today, there are 880,000. The second part of this program was the Georgia Access Model, which is now, the approach that we are taking is to establish a state-based exchange, which will transition the enrollment platform from healthcare.gov down to our own state-based platform that the state will manage and operate through Commissioner King and his office at the Department of Insurance. Last year, there was already some investment for the Georgia Access program that allowed the Department of Insurance to, promote more marketing and outreach, to facilitate more enrollment in the individual market. And already we've seen, the results of that just from what they've already invested. The enrollment has increased compared to last year in 2022 to current enrollment in 23. It went up 25%. Nationally, enrollment went up 12%. So we increased our enrollment double compared to states collectively nationwide. And we're hoping to build on that progress with the implementation of a state-based exchange, which will go live on November 1st, 2023. That is the target date for implementation. So I know Commissioner Noggle mentioned the Georgia Pathways program. Also wanted to hit on that program. As you can see, the waiver program is a partial expansion of Medicaid for able-bodied but low-income Georgians under 100% FPL, ages 19 through 64. So this provides a new coverage option to Georgians who currently fall in the coverage gap. They make too much and don't qualify for the traditional Medicaid program, but they don't make enough to qualify for the advanced premium tax credits that allow individuals to purchase subsidized or free insurance on the individual market. So through this program, 376,000 Georgians will have the option to pursue coverage for this program if they meet 80 hours per month of community engagement requirements, which include attending school, volunteering, or working, and they will have the opportunity to pursue this coverage option. And unlike a traditional Medicaid expansion up to 138% of the federal poverty level, these two waiver programs working together will not kick 200,000 people off of private insurance, because if the state were to expand Medicaid up to 138%, those Georgians falling between 100 and 138% would no longer qualify for those tax credits, which allow them right now to purchase insurance on the private market for free. Really, these waivers working together, we feel is a superior approach to a traditional Medicaid expansion, because when folks are covered by private insurance and commercial plans, they have better access to provider networks, and providers also get a higher reimbursement rate on commercial plans. It's much higher than what Medicaid reimburses. So we strongly feel that this is the best approach for Georgia. Happy to, and I know, see Russell still here, but, want to credit the Department of Community Health for their work on implementing this program, seeking to go live on July 1st. So we were delayed due to the federal government rescinding certain authorities in the program, and we challenged that in court and won. So we're delayed in implementing it from when we initially wanted to start implementation, but we are working very hard collectively as a state to get that program running on July 1st. So now I wanted to transition into health initiatives specific to OHSC and what we've been working on since we first started. I'll go through those quickly here. The first one is implementation of the All-Payer Claims Database, or the APCD. Second is a review of the Medicaid Managed Care CMO contracts and providing recommendations to the department on improvements to those contracts. We also, per 1013, had 2 assigned studies that we completed on the emergency transport for individuals to ERET facilities, as well as a recommended formulary for SHBP, which is a unified drug list, as well as a preferred drug list for Medicaid, and made those recommendations per our directive in House Bill 1013. And then lastly, want to also touch on some data projects and data initiatives that our office has worked on as well. So just a little background on the APCD. This was a directive that we received in Senate Bill 482, which passed during the 2020 legislative session, championed by former Senator Dean Burke, who was just in the room. And he also championed the initiative to establish our office. So credit to him for his ongoing support. But Senate Bill 482 directed OHSC to establish an all-payer claims database. And this has been done in about 20 other states, and so that was one of the first projects that we really undertook as an office. So for those of you not familiar with an APCD is a centralized data repository of healthcare, pharmacy, and dental claims from both public and private payer sources. So really it is a repository where health payers will be required to submit claims information so that the state can then take this claims information and conduct use cases and really leverage data to understand what different payers are paying for healthcare services at different facilities in the state. And we really hope that the APCD will help promote price, cost, and quality transparency, help us assess geographic variations in pricing utilization, track the healthcare spending drivers and trends, and promote public health. And it really provides a new level of transparency that has not existed before. So a lot of this information has been proprietary before. We don't know what certain payers are paying for certain services at certain facilities, but with this APCD data, we will take the data, ingest it, and then in a secure environment, hold it, and then be able to conduct those analytic use cases and really apply that data and make it useful to policymakers and the public. There are several entities involved in this project at the state level. Our office is charged with mandating and creating, mandating and creating the APCD. So we really oversee and operate the budget for this and help drive overall strategy and project direction. We have assistance from the Georgia Tech Research Institute, Center for Health Analytics Informatics, GTRI. They will be helping us and by serving as the administrator, so helping to arrange agreements and set up agreements for new payers to submit data to the APCD, as well as help with the 12 priority analytic use cases that I'll get into in a second. GTA has provided project assurance for the project and managed the IVMV vendor. The Georgia Data Analytics Center at OPB will help house the analytics environment. And then we recently brought on our data collection partner, and the approach that we took to implementing this was really utilizing a vendor that has already established this in other states so that they could quickly establish and deploy this environment to start collecting the data versus building something from scratch. So that'll really allow us to expedite the timeline. This slide gives an overview of the different plans that will be required to submit data to the APCD. So commercial insurance plans with at least 1,000 covered lives, Medicaid and the state health benefit plan from the government side. Certain entities such as ERISA plans are not required to submit data, but we hope that they will choose to do so. A lot of them do submit. They provide a opt-in option for their plans that they work with, or an opt-out provision. So a lot of them are used to doing this in other states. So we've been working closely with the plans through several work groups to help demonstrate the benefits of submitting data, not only to them but to the state. So we're hoping that a lot will participate. This slide shows the initial prioritized use cases. We had a use cases work group that consisted of different individuals from government agencies, from academic institutions, from health plans and payers, providers, hospitals, pharmacies. So this group really reviewed the national landscape and looked at what all use cases and what are the ways in which APC data can be used, and they also balanced that with what was feasible given our accelerated timeline to really prioritize as the top use cases. So I'm not going to read through all of these, but you can kind of see here what we're prioritizing with total costs of care, as well as surprise billing is a key use case that we'll be working with Department of Insurance on. The APCD will determine the median contracted rate by which surprise bills are paid, and several other use cases, as you can see. I did want to highlight one use case just to really demonstrate how beneficial this can be. So this is a use case that the state of Virginia did on potentially avoidable emergency department usage. And so utilizing its APC data, Virginia found that roughly 14% of their emergency department visits in the year 2017 may have been potentially avoided and treated in lower cost care settings, which we know that emergency department is likely the most expensive place that someone can receive care, and oftentimes it's very unnecessary if it is not. Here there are several examples on that graphic of issues that they identified that could have been these individuals could have been served in a different setting, such as a urgent care, primary care provider, and it would have cost much less. And they totaled that it was potentially $100 million of potential savings. Now, implementing that would be more difficult than just because it's hard to get people directed to the right place. But there are policy levers and actions that the state and others can take and plans can take to help drive people to the lowest cost setting and most effective setting to receive health care. So here are some key milestone dates with APCD implementation. We have our data collection vendor OnPoint on board, and they are establishing the environment that will be established to start receiving the claims data. We have finalized the data submission guide and the rules for payers to submit. So we had a public comment period and we're able to receive input from payers, and we have published those guidelines now for them to begin the process of submitting that data. Submissions for health and pharmacy plans will be due on June 1st of this year. Submissions for dental plans December 1st. And then the first analytic use cases we're hoping to develop and publish by January of next year. And then all payers, including all statutorily mandated payers, Medicare, other payers that we're hoping to get, should be in the system by December of 2024. And this is just an overview of the budget so far for the project. The governor's budget recommendation just makes a request that $800,000 in base funding for the project be transferred to our office from DCH. Through a partnership with DCH, we've worked with them on accessing and spending these funds, but now that we're an established office with a full team and staff, the governor's recommended to transfer that money. And the good thing about this project is we are able to utilize federal funding at a match percentage, FMAP, 90-10 funding for implementation, so we get 90% of costs funded from the federal government, and that's due to the benefit that the government sees from us utilizing this Medicaid data, getting better insight on into Medicaid data and how it's how what Medicaid is paying for, what services individuals are accessing. So there's a significant benefit there that they're helping invest for the project. The next initiative I wanted to go over, this is another directive that was assigned in statute in our legislation that established the office in 2019 to conduct a review of the Medicaid managed care contracts and make recommendations to DCH on those contracts. So we worked with Sellers Dorsey, a Medicaid consulting firm, to review those contracts, really look at the national landscape and see what innovations other states were deploying in their Medicaid programs, and then also a review of our current contracts to see what is in those contracts, what could be potential, what potential there could be for further improvements and enhancements to those contracts. So that report is available. I've shared it with some of you. Happy to do so. It's on our website, but really looked in several different category areas and really looked at it holistically. Some that I'll just mention briefly are improving care coordination. So the state being very specific about establishing care coordination tiers and what areas of care coordination individuals should be assigned to. That's one of the biggest benefits of Medicaid managed care is the coordinated care and really management of overall health that can be provided to individuals. So we want to make sure that we're setting expectations and be able to enforce certain provisions of those contracts. Social determinants of health is another key area. So looking at housing supports, transportation supports, access to nutrition and food. That's another area that through these contracts the state can direct the plans to for example conduct closed loop referrals. So really ensure that when you recommend someone to a community-based organization for help with transportation, food, or housing, that they get the services they need and that you're tracking that and managing it to see if they've followed up and kind of close that referral loop. Those are several of the key areas, as well as I'll just say the opportunity for the state really to work collectively in managing these contracts and really leveraging. There are several agencies that are very involved with managing these different populations. So it'll be really important for the state to be working together and have several different agencies helping to oversee the contracts and ensuring providing assistance because they have expertise with those different populations. The next project and initiative that I wanted to go over, this was another directive that we received from House Bill 1013 to conduct a emergency transport study. We were tasked with conducting a survey of transport of individuals to and from ERET facilities. Really, this had come out of a lot of frustration that I think law enforcement and the sheriffs were having with, having to, especially in rural areas and underserved areas, having to transport individuals in crisis for long periods of time, long distances, having to wait at facilities with individuals, and that being unfunded and not taking away from their public safety mission, or being out in the community and attending to other needs of the community. So this study really quantified where individuals were coming from, what counties they were coming from, what facilities they were going to, and then at discharge, who was transporting them from discharge, where were they taking them, and looking at the costs, the overall cost as well. So those were several key considerations. One of the main findings was that ambulances were used, most of the time to, I think they were really the highest transport, at least for the highest method of transport, for admissions, but they're also the most expensive. So that was interesting, as well as really, we also went further with this study beyond just what the directive in House Bill 1013 instructed us to do. We looked at other states and how they've managed this problem. It's occurred in other states, so we looked at Virginia and Tennessee. They both have statewide grant programs for this. Tennessee provides grant funding to local counties and governments, and Virginia operates a non-emergency medical transport contract, so they help provide assistance there. And then we also just assessed provided recommendations around bed coordination, some considerations for DBHCD and law enforcement and sheriffs in determining, really utilizing the GCAL, which will be 988 line, to help provide recommendations for transport on where to take individuals, where there was capacity. So there's really a lot of there's potential for technology to be used here to help make sure that this is efficient, and that there aren't unnecessary delays in transporting people long periods of time to facilities that may or may not have capacity available. So the next project that I wanted to go over is the preferred drug list study. I know this has been a lot of interest to a lot of individuals in the legislature. Currently, we have 4 different plans on Medicaid that operate 4 different preferred drug lists. And then we have the state health benefit plan that has 3 plans, 2 of which utilize the same pharmacy drug list, and one of which is not. So the direction from the legislature in House Bill 1013 for us was to conduct a review of those drug lists and provide recommendations on what it would look like to go to one unified drug list in Medicaid, as well as one drug list in SHBP, and conduct that assessment and recommend how those lists would be unified and reconciled. So we looked at a lot of different clinical data and considerations. We also looked to assess the current list to see, what disruption could potentially occur. How aligned are they already? We found that they are mostly aligned for the most part. I think 88% on SHBP, 63% on Medicaid. But when you really look at individuals, it's even further aligned, because a lot of times it's only, for example, fee for service that has a difference, and all the managed care plans are doing the same thing. So that report is also available on our website. Happy to share that with anyone. One just potential caveat I'll mention with this study is we were not able to access the rebate data, so we could not conduct a full fiscal analysis due to that data being proprietary, but we were able to do the member disruption analysis, look at the clinical considerations, and in the report that we sent to the Department of Community Health, we did include steps that could be taken to conduct that fiscal analysis, since they have the access to that confidential rebate information. So they will be able to, if they choose, to finish out that study if the state is looking at implementing unified drug lists going forward. But there are several advantages to moving forward with one unified list. It provides for simplification for providers and patients, knowing that if you're on Medicaid or if you're on SHBP, you have access to one list of drugs. They're not having to worry which plan or which CMO is covering an individual. There's also some big financial considerations with this. As I mentioned, that rebate piece is really important because the CMOs do not currently have insider access to the rebate information. So they may be choosing certain drugs for their drug lists that may be higher cost for the state than a brand name drug that the state is receiving rebates for. But since they don't have access to that information, they're not taking that into consideration. So there are some financial considerations for the state on that end, as well as just overall negotiating and bargaining leverage for those rebates. If you had a unified list, you'd have a bigger population. Now there are some downsides to the list. I think the plans to some degree, and they have more autonomy now to select their preferred lists. There's also considerations about pharmacies having availability of brand name drugs. So there's some considerations on both sides, but our report kind of goes through those as well.
I'm glad to hear that Governor's number one man cannot see those rebates either. We've been trying for years, but I understand the confidentiality, but your access would be very critical to making really good decisions.
Right.
Go ahead.
So then I'm on to our next initiative was several data projects are underway. So we've developed a partnership with the Georgia Data Analytics Center, who also presented with us. Conti Chalasani, their director, presented with us at joint appropriations, and really went over some of the data projects we were instructed to work on. There was a budget line item in last year's budget that appropriated us funding to look at take hospital transparency data that the state is already collecting. DCH collects this through their annual financial surveys, and we already have access to it. But I think for some time there wasn't anything being done with that data, or it was very hard to, you'd have to go to each individual hospital report to access the financial information that it collected. So I think the legislature, wanted us to really take a look at how we can take that data that the state already collects and put it in one unified format and aggregate it so that, policymakers, legislators, members of the public can go to one site in particular and can see all that information in one place and not have to, go through, long documents to pull all the information that they need. So that is a look at the hospital transparency dashboard. That is just a screenshot of it, but encourage you, if you're interested, to go to, it's accessible on our website as well as the GDAC website, where you can go to each hospital and see the information that they are reporting. And so this is really built off of House Bill, I believe it was House Bill 186 and House Bill 321 to increase hospital transparency reporting requirements. There are some additional items in statute that they're required to report that are not in the hospital financial survey, but we're working with the department to see how we could potentially access those additional fields, because what you see on the screen right there, charity care expenses, charity care percent of total expense, et cetera, those are really the only fields on the financial survey. So we just need to find a way to more easily collect some of that information that they're already reporting in other areas, but those are future steps and next phases of the project, as well as next wanted to go into just some potential data sharing opportunities and considerations for the state. So, as you can see with the hospital transparency dashboard, and GDAC is also doing a lot of work. They presented on their other healthcare dashboards at the joint appropriations meeting, just looking at different, nurses, physicians, PAs. They've got several different dashboards that you can access to see where individuals are practicing in the state, what areas have gaps, where new graduates are coming from. So there's really a lot of value in taking data that what we've found is the state is actually collecting a lot of data through surveys, through professional licensing boards and other means, but we're not fully leveraging it and taking that data and putting it, doing the work, analysis, and analytics that it takes to put that in one place for people to easily navigate. So the Behavioral Health Commission report for 2022, we worked with Chairman Tanner and the BHRIC to present to their subcommittees over the summer and fall and work with them on conducting more research on what can be done at a state level to open up data sharing and facilitate data sharing more easily and readily between agencies, and a lot of those provisions, are included in House Bill 520. But these are some of them on the screen. Including just having a uniform process by which data can be shared and creating a presumption of data sharing across state agencies.
How about House Bill 1276 requiring data sharing and DCH reporting of CMOs? Are you aware of that one?
I don't think I've
That was
seen
passed
that one.
last year.
Okay.
Yeah. It should be some good information in
Okay.
there. Jesse Wethington and I worked on that bill pretty extensively.
Great.
Yeah.
Yeah.
Mr. Chairman, they're up and
Right.
we're in flight, kind of always
Right.
tweaking and improving, but the financial dashboards are available. We can help anyone through that should you need.
Yeah. I think it'd be very helpful to y'all to be looking at that with,
Absolutely.
yeah, for Medicaid.
Well, with that, I think that those are the projects and initiatives and some of what I wanted to go over today and provide to you all. But Chairman Hawkins, really appreciate the opportunity to be with you today and present on these different initiatives, and happy to take any questions or thoughts, feedback that y'all have.
Well, listen, I really appreciate all the information. I do have one question for you myself. On the all-payer claims database, I noticed that you were including Medicaid.
Yes.
Is that correct?
Yes. Yep.
Surprise billing, we expressly excluded Medicaid because of the effects on the. So are you going to factor in that legislation? So so
Yes.
you'll have two batches, including Medicaid and not including Medicaid.
Yeah, so the APCD project is really two separate parts. There's two different phases of that project. The first is the data collection phase, where we take in the information from the payers and get all the claims data into the system.
Right.
The second phase is the analytics part, where all those use cases, we'll be taking the data to help determine, how we use that data to conduct those use cases. Surprise billing being one of those. The Department of Insurance will be able to access, that information for that use case, specific to the plans and the payers that were stipulated in that legislation or, under their guidelines. So if Medicaid is not in that, bill, that is not good. Medicaid data will not be utilized for that.
Good.
Use
So you'll
case.
have two separate
Exactly.
banks of data.
Exactly. Yeah.
Good.
Yeah.
Good. That's very important.
And we've had a data security and privacy committee, so all the committee's really looked at how to guard and protect this data and that make sure that the appropriate protocols are in place so that data is not shared unauthorized. There will be a review committee that reviews requests for this data,
Right.
the ability of the requester to keep the data secure. Do they, is it enough of a data pool that they're not going to be able to identify it? So really ensuring that the data we have is guarded and that we're not, that it's protected and that no identified data is getting
Great.
shared.
Thank you. Ripson and Newton.
Thank you, Mr. Chairman, and thank you for the presentation. I think that's a bold agenda with a lot of different moving parts. Following up on the all-payer claims database, with the CMS having a hospital transparency pricing piece that finally went into effect, I know it was two different administrations that have done it. It's supposed to provide the actual, not only the charge, but it's also to provide the cash price if there's a discount for self-pay or cash, and
Right.
then also to provide what the insurer paid. My understanding is that data available to maybe to plug in or to check the data that's reported on the database, because if that's available and supposedly in this what they call machine readable, it seems like it might be a quick way to get a whole lot of all payer claims data to inform it. But I was just wondering if that's going to I know the price isn't everything. Quality figures in there. If the
Yeah.
price is lower on one, but then the complications are higher, you wouldn't necessarily say which one is the most valuable just because of the price. But I was wondering if y'all were thinking about using that as to help either check or to actually fill in a lot of the data that might be needed?
So they're really two complementary data sets. I think what the federal government has done through that transparency rule will give a better understanding of like what the list prices are, and I'll have to go back with our analytics team and get the exact breakdown. But my understanding is that what we're doing will be complementary, and the new data that they're able to access through that rule will be additional data that we can pair together and really create a more full picture. But it's not duplicative at all. What we're doing is unique because it's really what each individual claim is paid through a payer's agreement with the facility, which can vary widely from whatever the list price or whatever price was charged initially by the provider or the hospital. So.
If you don't mind, one follow-up question on the preferred drug list question. I know you said that, but you don't really know the price necessarily. Just one thing we've come across was on a preferred drugs is sometimes that a longer acting medication might be a good bit more expensive on the front end, certainly for the pharmaceutical, with or without calculating in the rebate that might be applicable. But if you factor it, so the pharmacy price might be more, but the medical expenses might go down with medicines that work for a month at a time and help keep you out of the emergency department with a mental health challenge, help keep you working, paying taxes instead of being transported back and forth like the emergency transport. Is that being calculated in when you do a recommended or preferred drug list? That's one question. And the second is that prior authorization can be a simple phone call, which is a little interrupting if you're in a fast-paced office. It can be bad enough, but then there can be other requirements in prior authorization. I've seen this where a drug is, quote, a preferred drug, but it requires PA, or prior authorization, which might mean a long time on hold. It might mean you got to send in documentation that the patient's been on it for 3 months. So I just wonder if, while we're deciding this preferred drug list, have we been able to, with the information you have, to calculate in that potential medical benefit while you're looking at the price discrepancy?
Yeah. So I think, on your can you repeat your first question again?
I guess it's just, are we looking at the long-acting medications and the price, and are we trying to assure that they're going to be offered, and in particular, if they might lower the overall cost of health care for these individuals with these needs? And the second was whether prior authorization can be so onerous that it, even if they're on the preferred drug list, they can be very not preferred by the person prescribing.
Right. Yeah, so our study really focused on, those clinical considerations, the member disruption piece. Since there was so much alignment already, that was a key factor. There was not a lot of variation between
the different CMOs and
yes,
things.
yeah,
Okay,
between the
thank
different
you.
CMOs. Now there was a little more on fee for service than CMOs, but really, a lot of times there would be 2 or 3 that already had the same list, but there was maybe one list, that didn't. But those are just additional factors that, that there would still be work. This isn't like ready to go and implement tomorrow, since there does have to be that fiscal analysis, that vetting through certain committees that DCH has. So it would not, there's still additional work that has to be done. These recommendations are really just a first step.
Well, thank you for getting on it. I appreciate it.
Again, I want to thank you for coming and all the work you've been doing. Like I said in one of our appropriations meetings, I'm very impressed at how fast y'all have stood this up, you and Elizabeth Holcomb and your whole team. This is a mammoth amount of work. I also want to commend our governor for taking this step. I mean, we have worked in silos since I've been involved in government for 17 years, going from one department to another, and we spent more time tracking around than we did actually going forward. And what you're doing is we're all going to go forward and rapidly, and I want to thank y'all very much.
Thank you.
If there are any more questions, this concludes our meeting. Thank you all.